All right. Hello and welcome you all on our today's event, which is about neurosurgery. And the event is the International Live Conference on Neurosurgery 2023. First of all, I would like to ask to all of our attendees in the meeting room and also in the LinkedIn Live, please confirm if I'm audible to all of you. Just writing a simple yes. Thank you, Dr. Diyar. And to others also, please confirm if I'm audible to all of you. You can simply write a little yes in the chat room. Thank you. Thank you. Thank you. All right. So thank you so much to all the attendees from LinkedIn Live as well. They are confirming and cooperating very well with me. Thanks a lot to all of you. Okay, let me introduce myself now. Hello, everyone. My name is Ghazal Johar, and I'll be the moderator of the day. And thank you so much for joining us here. Okay, I'm seeing a little question. You all are asking the LinkedIn Live also. And some of you were asking me in the meeting room also earlier than we started. Okay, there's a conflict about who will get the certificates and where are the links. Okay, so the link were present on our all the social media platforms for this meeting. And so many of you who are in the meeting room right now, you registered for it and you got the login details also. So those who are asking the LinkedIn Live also, you can go to our website and register for the event right now. And yes, it is the policy that the certificates will be provided only to the attendees who have registered for the event and who will be joining the event for at least 40% of the time of the whole event. I hope I'm clear about the idea. Yes, thank you so much for cooperating. All right. So I see our OCM, Dr. Sampurnam, is also here. And we have a little small surprise also, something to announce at the end of this event. So stay tuned, and we hope that it'll be useful to all of the people present here. Also, if you are having any question related to the meeting, related to the speaker or the specific talk, you can write down the question firstly in the chat room, and we can discuss the question later on with the speaker. Yes? And the same is for the attendees from LinkedIn Live also. They can write down the question in the comment section, and I'll try my best to pick the question and drag it here in the meeting room for you. All right. And one more thing, as so many times our team faced this issue that there are attendees in the meeting room right now, but later on they leave the meeting room due to some circumstances, and they didn't get the certificate on time. So apologies, but the thing is, when I'll be asking about the details like your name, your title, and your email address after the meeting room, after the meeting, after any talk, then please provide with the details to me. And our team will be able to provide the certificates to only those people who will be providing these details. And I'll be asking the details later on. I'll definitely let you know. That is for only the people who are in the meeting room right now. Okay. So in case, please, dear team, help the people in the meeting room or in the LinkedIn live stream also. Whosoever is asking for the link, please provide the link to them to register. All right. So today we'll be having 2 speakers. It is a teamwork. And the team is Dr. Habchi Nawel. She's one of our OCM also. And Professor Mehdi Dermoul. Dear Saido, Payam Saido, I'm sorry, you are asking for the registration link, but you are already in the meeting room. So what else are you asking for the registration link, please? There might be a confusion. Dear, you are already in the meeting room, so you don't need any registration link. You already registered and you got the details, and you are in the meeting room right now. Here comes our speaker, and here comes our speaker, OCM, I should say, Dr. Habchi Nawel.
Good evening, everybody. How are you?
I'm good. Good evening, Dr. Habchi. How are you?
Fine. I am in holidays.
Okay. You told me about the vacation time going on there. Yeah. That's nice. I used to think that doctors don't get any vacations, but now I'm pretty much in relief to know that, yes, they get the vacations also. So the profession is worth it now.
Yes.
Yes.
I am honored to attend this interesting conference with you, and through which we will show you the latest discovery and development in the fields of neurosciences and neurosurgery. And as always, I gave to you a detailed explanation of the disease. If you remember, my conference plan is divided in 2 parts. In the first part, I showed to you what is the pathology, the diagnosis, the radiological exploration, and the management and the treatment. Then I pass to the second part of my conference, in which I show you the latest investigation and my work. This is the plan of my conference.
A very well planned. Yeah. I'm sorry, I was distracted from the compliments I'm getting for you. Okay. So I'm glad we are coming with a plan, and this whole event is will be handled by you, of course. You'll be the chairperson. Okay. So
thank you very much.
Yeah. So about the surprise we got for all of the attendees and speakers and all of the people related with the all shares, we are having a surprise, and Dr. Habchi will be the one revealing the surprise at the end.
Okay, at the end of our conference, we will show you this surprise.
Yeah.
Okay.
So shall we go with the talk now, Dr. Habchi? Are you comfortable? Are you ready?
Yes, I can present my conference. I'm ready. So
Perfect.
now I show my presentation. Okay.
All right. Till then, let me introduce Dr. Habchi Nawel, the National Hospital from the National Hospital for Neurology and Neurosurgery and University of Victoria, London, UK.
Okay.
So the title of the talk will be Intracranial Meningiomas, Prognostic Factors and Treatment. As I mentioned earlier, it will be a teamwork from Dr. Habchi Nawel and Dr. Mehdi Dermoul. First, Dr. Habchi Nawel is coming up on the screen to explain her part of the talk. I repeat, any questions from Dr. Habchi Nawel can be asked later on. You can write down your question first in the chat room, and later on you can come up on your screen and ask the question or discuss anything you would like to know or discuss about. Yes? I must say to all of the
Okay.
attendees, yeah, I'm sorry.
Yes. Can you see the flyers?
Yes,
Okay.
slides are visible. They just need to be, yeah, excellent. Yeah.
So as I said before that my conference is divided into two parts. In the first part, we will give you a general definition of the disease, the diagnosis strategy, the radiological exploration, treatment, and management. Then I pass to the second part of my conference, in which I present to you my investigation and the work. So the title of my conference is Intracranial Meningioma, Prognostic Factor and Treatment. So you pose the question, what is meningioma? Meningioma is a kind of a tumor that arises from the meninge. And this meninge is our membrane that surround our brain and the spinal cord. This meningioma is the most common type of the tumor that form in our head. And the most meningioma grow very slowly over many years without causing symptom. But in some cases, it can affect nearby brain tissue, a vessel, a nerve, and cause a serious disability. Look here. This is the three meninges. We have dura mater, pia mater, and between them, the arachnoid mater. So the meningioma arises from the meningothelial and arachnoid capsule. This is the place of raising of meningioma, and it can progress and invade the dura mater. This is the definition of meningioma. It is considered as a benign tumor, but in some cases, it can be a malignant. This is the common location of meningioma. It can be a parasagittal here, or it can be in the convexity, in the forks, in the sphenoid ridge or olfactory groove, and also in some cases, we can see meningioma in foramen magnum. And according to these locations, we have a different symptom. We can have headaches, seizure, changes in personality and behavior, progressive focal neurologic deficit, confusion, drowsiness, the hearing loss of ranging into ear, and also muscular weakness. In some cases, we have the sign of hypertension, intracranial hypertension. We have vomiting. And also, when the meningioma is placed in sphenoid ridge, we can have a visual disorder. So the radiological exploration is based on these three modalities. We have the brain, a plain film, CT scan, and MRI. The CT scan is considered as a first investigation for the neurological signs. In CT scan, we can see this sharply circumscribed and looked mass, and here we have broad-based dural attachment. This dural attachment is the characteristic of the skin of the tumor. In some cases, we have the calcification, and this calcification can be associated with hyperostosis and lytic lesion. The lytic lesion is located in the bone. This is the radiological characteristic of meningioma. As I say, the characteristic of this mass is the broad-based dural attachment, and we confirm this with MRI. So this broad-based dural attachment can define the border of this meningioma. So it is characteristic of the skin of tumor, and also it defined the border of this meningioma. So look here, this is the mass. And here we have CSF cleft sign. And also the vessels are patched inside. This is the picture of meningioma. Radiologically, this meningioma is defined as extraaxial tumor and not intraaxial tumor. In the case of extraaxial tumor, here within CSF space, here this space displaces the brain deeper, while in the case of intraaxial lesion, here the narrow CSF space displaces the cortex toward the periphery. This is the difference between the extraaxial and intraaxial lesion. Here, the brain is displaced toward a periphery. However, here, this within CSF space displaces the brain deeper. Okay, this is the difference between the two. As I said before, the radiological definition of meningioma is extraaxial lesion and not intraaxial lesion. So the symptoms differ or depend on the basis of the location. In the case of pulse or parasagittal locations, the symptoms differ if we have another sphenoidal meningioma. And here we have the details. In the case of parasagittal meningioma, we have monoparesis of the contralateral lobe. This is in the case of the parasagittal meningioma. In the case of the convexity meningioma, it depends on the lobe involved. If we have a problem, for instance, if we have a location of a temporal here, we can have some seizure. When we have sphenoid ridge meningioma, we have some abnormality of the vision. We have a problem of the vision. The multiple cranial nerve palsy are involved if the superficial orbital fissure is involved. And also, in the case of supracellular meningioma, we have the problem of vision and also panhypopituitarism. This is the characteristic of meningioma, suprasellar meningioma. When we have posterior fossa meningioma, here we have another problem. We can have imbalance, nystagmus, respiratory and cardiovascular problem, and also ataxia. So look here, the symptoms are not in the case of sphenoid-rich meningioma or suprasellar meningioma. This is why I say that the symptoms differ according to the location of the skin of the tumor. For instance, in the case of olfactory meningioma, here we have one syndrome named Foster-Kennedy syndrome. You pose a question, what is this Foster-Kennedy syndrome? It is an association of anosmia, the lossing of anosmia. Also, we have the optic atrophy and papilla edema. This is the three signs of this Foster-Kennedy symptom. When we have foramen magnum meningeal, here we have paraparesis, sphincteric troubles, and the tongue atrophy. And in the case of spinal meningioma, we have localized pain, and it differs according to location of this spinal meningioma. And also we have the brown square syndrome. When we have optic nerve sheath meningioma, we will have monoocular vision loss. This is the optic nerve. And also we will have exophthalmos. When we have a cerebellopontine inguinal meningioma, here, this is the cerebellopontine inguinal. Here, we will have a decreased hearing with a possible facial weakness and numbness. This is the characteristic of cerebellopontine inguinal meningioma. When we have optic nerve sheath meningioma, we will have a problem in vision. And when we have a cerebellopontine inguinal meningioma, we will have a problem in audition. So you decrease your hearing. According to the World Health Organization grading, we have 3 grades. We have grade 1, grade 2, and grade 3. This classification is considered as a gold standard for the histological and etiological classification of the skin of the tumor. Look here. According to 2016 WHO classification, we have 15 subtypes and 3 grades. The first grade, WHO grade 1, this is the histopathological characteristic of grade 1. It is considered as a benign tumor. In the second grade, it is atypical meningioma, atypical tumor. And in the third grade, we have anaplastic meningioma. This is malignant. It is a malignant tumor. Look, in the grade 1, benign. In the grade 3, malignant. And we have 15 subtypes. In the grade 1, we have 9 subtypes. We have meningothelial, we have a fibrous, we have transitional, pseudomatous, secretory. All this is benign tumor. However, in the second and in the third grade, we have 3 subtypes. Look here. This is the latest article published this year. It is published in April of this year. So the title is the review and management of the diagnosis of meningioma. In this article, I found some characteristics. Look to this table. This table presents the common genetic alteration in case of meningiomas. According to the location, we have convexity meningioma, and the new data that are each meningioma location have meningioma subtypes. For the case of convexity meningioma, we have fibrous transitional subtype. In the case of skull-based meningioma, we have meningothelial, microcystic, and secretory subtypes. In the case of spinal cord meningioma, we have clear cell and rhabdoid subtypes. This is the news of this year. The subtypes according to the location. And also, we have the common genetic alteration. So, this table outlines a common molecular biomarker used in meningioma diagnostic according to 2021 guideline. This is the news of this year. So we have a correlation between the location and subtypes, and also we have a common genetic alteration according to the location. Before, we have not these informations. Now we pass to management and the treatment. The management and the treatment of meningioma depend on the size of the tumor and also the gradient and the location. The current treatment strategy can be determined based on two types of meningiomas, asymptomatic and symptomatic meningioma. In the case of asymptomatic meningiomas, we use the observation, only the observation. So, for the small asymptomatic meningioma, a watchful waiting strategy is usually recommended. The clinical observation and MRI screening are performed every 6 months following the initial diagnosis. And the patient that remains asymptomatic until 5 years are then seen for annual observation only. This is for the case of asymptomatic meningioma. In this case, we do the MRI screening and clinical observation. In the case of symptomatic meningioma, here we have other option. The surgical resection remains the best one and the first line of the treatment. But in some cases, we have a problem. For instance, the elderly or disabled individual, or this person have the option to choose of either stereotactic radiotherapy or radiosurgery or chemotherapy as a primary treatment. But this surgical resection remains the first line of treatment. We have some advancement in operating techniques, including a surgical microscopy, neuronavigation, intraoperative monitoring, imaging, and endovascular approaches. All this have allowed for more radical resection. So the objective of neurosurgeon is to do radical resection. It is the best way. So here we have a surgical classification named Simpson grad. So Donald Simpson have proposed this classification in 1957. We have 5 grades. This Simpson grading have a great role in prognosis and also in the follow-up of our patient. In the first grade, we have a complete removal. We have a resection of underlying bone associated with a dura. In the second grade, we have a resection and coagulation of associated dura. However, in the third grade, we have a complete removal without resection and coagulation of a dura. And in the fourth grade, we have the subtoptal resection And in the last grade, the fifth grade, we have the decompression with or without the biopsy. The Simpson grading remain a reliable tool or useful tool for classifying the extent of surgical resection. And the characteristic of recurrence rate is correlated to this grade. Many studies show that the recurrence rate appear 9% in the grade 1 when we have a complete removal with resection of underlying bone and associated dura. Here we have 9% of recurrence. In the second grade, we have 19%. And in the last grade, we have 29%. Now we pass to risk factor. Risk factor include exposure to radiation, neurofibromatosis, number 2, and the case of possible oral contraceptive and the use of hormonal therapy. And also, in some study, we have the case of intrathecal methotrexate and the obesity, especially for the woman. Look here. This is the last data. The last data published by the Brain Sciences Foundation. According to this foundation, we have some funding. This funding that pushed me to carry out a survey of Algerian simple. Look to the first finding. Here, we have increased occurrence of meningioma in a post-pubertal woman compared with a man. The second finding, the higher female incidence ratio during the reproductive years that disappear with increased age. And also, we have the detection of estrogen, progesterone, and androgen receptor in the significant number of meningiomas. And also, it is very important for the woman. Here, we have a link between the breast cancer and the occurrence of meningioma. And also, we have the connection between meningioma growth, menstrual cycles, and pregnancy. Look to this finding. It shows that there is a correlation between the occurrence of meningioma and hormones. So the researchers are beginning to explore the possible connection between the occurrence of meningioma risk and the use of oral contraceptive and hormonal replacement therapy procedure. Furthermore, an association between the obesity and meningioma incidence are shown in several studies. This data pushed me to carry out a survey about Algerian population. This is my investigation. So I did a retrospective study spread over 11 years from 2012 to March of this year. During this period, we received 164 patients. We have 111 women and 53 men. And analysis was carried out based on gender, ages, gradient, topography, a number of pregnancy, recurrence, and death. According to this parameter, we are doing our study. So we are doing a multivariate analysis according to 2 parameters and 3 parameters. And we have found that women is the most affected by this kind of tumor. Look here, we have more than 67% of our population are women, and the sex ratio is 2.09. This is the distribution of intracranial meningioma according to the gender. This is presented by the hormonal theory. This hormonal theory suggests that the progesterone is the cause of occurrence and the growth of this kind of a tumor. The most affected age group is between 50 and 60 years. And in our population, the average age is 52. But in some literary review, we found that the average age is under 50 years, as the Senegal author Thiam and al. Who found that the average age is 47. In our population, we found more than 65% grade 1, the benign tumor, grade 2, 34. However, we don't found the grade 3, malignant tumor. According to the topography, we found that the most affected location is the convexity. And this is explained by the high incidence of the convex tumor is explained by the tolerance and the plasticity of the cerebellum parenchyma, which prevent the development of a tumor occupying 2/3 of the space reserved for the lobe, especially since it is possible and occur that at the contract and the depressive area. This is the explanation of the predominance of convexity meningioma. In our population, we found 9% of the death. And look to this figure. It is very, very important for the woman. We noticed that we have more than 87% of our women have 3 or more children before the age of 40 years. So this result led me to find that a woman with 3 or more children before the age of 14 may contract a higher risk of developing intracranial meningioma. And as you see before, the average age is 52 in our population. So women who have 3 children or more before the age of 40 years can contract the risk of developing intracranial meningioma. And we noticed that the recurrence appears in the grade 2. There is a correlation between the grading and the recurrence. We found 20.8 recurrence of our population. According to all these parameters, we find that the woman may contract a higher risk of developing meningioma, especially when they have 3 or more children before the age of 40 years. And as I say, the average age is 52. There is a many literature study that show that the risk of meningioma in a woman under the age of 50 years increase with the number of pregnancy compared with nulliparous women. In our study, as I showed before, we found that 55% cases have 3 children before the age of 40 years compared to 11% of nulliparous women. Indeed, these meningiomas are tumors sensitive to the hormones, and the combined action with the progesterone and the growth factor contribute to the growth of this kind of the tumor. The recurrence is more common is in grade 2. And this is after the average follow-up of 8 years. And this tumor recurrence led the surgeon or motivate the surgeon to do a second surgery, a second intervention. And here, he tried to do a Simpson 1 surgical excision. As a conclusion, we can say that our experience has clearly shown us that risk factor of occurrence of meningioma are: the first one, family sex; second one, age above 50 years; third one, a number of pregnancy greater than 3 before age of 40 years, and also the taking of progesterone. So, but in some cases, we have the variety of clinical presentation and location, and this is led the author to define or to categorize the meningioma as a separate tumor entity, and the management of this kind of a tumor is discussed case by case, and for the management or for the follow-up, it is adapted for each patient. For you, you pose a question. When I see the doctor, you see the doctor when you have a sudden onset seizure, when you have also a sudden changes in your memory or in your vision, and you must make an appointment to see your healthcare provider if you have a persistent sign or a symptom that concern you, such as headaches that worsen over the time. So if you have a sudden onset seizure, we have a problem of a vision, a sudden changes in your vision and memory, or we have headaches that worsen over the time, you must make appointment to see your healthcare provider. So this is the most important information for you. So you must know the risk factor of occurrence of this kind of the pathology. This is the risk factors for risk factors. And when you see the doctor, if you have a sudden onset of a seizure, if you have a sudden change in vision or memory, or if you have a headache that worsen over the time. This is the most important information for you. And thank you very much for your attention. If you have any question, you can ask me. And you can send me a message in the part of the discussion.
I see. Dr. Habchi is experienced well that I even don't have to announce a few things. And thank you so much. So thank
you very
so much. Yeah. So there was a question for you, Dr. Habchi.
So can you please explain specific medical management for meningioma? So Prof. Jeta Asharji, so ask this question for the medical management for meningioma. As I said before, it's depend on the location of the tumor. If you have a problem of the vision, or if you have a problem of, for instance, if you have a sphenoid reach meningioma, here you will have pan-hypopituitarism. So we have a problem in the hormones. So we will take a medical treatment according to the abnormality, hormonal abnormality. Okay, this is for the medical management of meningioma. It depends on the location of the tumor, the kind of the symptoms. Okay. Is there any question?
All right. Thank you so much to Dr. Acharji for the question and Dr. Habchi for taking the question. Asking for any more questions you're having from Dr. Habchi. You can come up on your screen or write down your question in the chat box. And to the people who are watching us live on the LinkedIn, if you are having any questions, please write down your question. I'll try my best to ask the question on your behalf. And yes, I'll thanks to Dr. Daud. She actually took her time out to join us.
Yes, Dr.
Yeah,
Dawood.
yeah, and a lot of your hard work, Dr. Habchi, you did so much hard work for preparing the surprise today.
Okay, at the end of a conference.
Yes. So I'm repeating. If you are having any question, you can write down your question in the chat box. Compliments for Dr. Habchi. Right, let us give okay, there are questions from Dr. Habchi on our LinkedIn Live. So our team will do one thing, copy the questions and paste the questions here in the chat box for you.
Okay.
Give me
no
a, just
problem.
give us a while. Yeah.
Thank you to Aisha for her message.
Thank you, Dr. Ashaji. It's always nice to have you in our events. Yes, definitely. You will get the certificates. Okay, about the certificates, let me take out 1 minute to announce about the issue I'm finding so many questions about. So I would like to repeat that the attendees or the speakers who have registered and are in the meeting room right now and are joining the meeting right now here will be provided with the certificates within the 3 next working days. All right. As it is Saturday in India. So you'll be provided with the certificates either on Monday, Tuesday, Wednesday, for sure. So here is the question which we get from LinkedIn from Sunidhi Kanpal.
What could be the differential diagnosis to the diagnostic differential diagnosis? So for these cases, yes, when we have a problem of when we have a seizure, as I said before, it depends of the location, but the radiological exploration show the characteristic of the meningioma. We have a dural attachment that characterize the meningioma, okay? So for the neurosurgeon, when we see the patient and he present the headaches and a seizure, we can propose a differential diagnosis, glioma or abscess. But when we do imaging, the MRI confirm the diagnosis. As I said before, the definition, the radiological definition of meningioma is extraaxial meningioma, and we have a dural attachment that gave a well-defined burden of dysmesis. This is the radiological definition. So in the clinical examination, we propose some diagnosis, but when we do the MRI, okay, this is extraaxial mesis and had dural attachment that gave the burden, defined the burden of this maze, and it is a characteristic of meningioma. This is the radiological definition of meningioma. So for the differential diagnosis is glioma, metastasis, but the radiological exploration defined this kind of the tumor. It gave the radiological characteristic of meningioma, extraaxial lesion, have dural attachment, This is the characteristic of meningioma.
All
Do you
right.
had any patient meningioma after radiation? Yes, we have some children who have mini radiation in childhood. So the radiation is a risk factor of occurrence and emergence of meningioma, especially the children. So when I see one children have 14 years, I ask him or I ask her mother if he had radiation CT scan before. So we have a correlation between the radiation and the occurrence of meningioma.
All right. So let me ask if we are still having more questions from LinkedIn.
Also, I noticed that he mentioned that the radiotherapy is a causes of occurrence of meningioma. If you remember, in the brain conference, I present a conference that showed the correlation between the emergence of the brain tumor and radiotherapy. So, for Farzad Sadluparisi, you can see my conference of a brain tumor. I held it in February, 4 February.
Yeah, yeah. So in case you want to go for that session also, the videos are presented on our YouTube channel.
Yes, in the
You
chain.
can go for it. Yeah. All right. Let me provide. Okay. There are some questions from LinkedIn about they can't reach to our registration link or something. You can go to our website directly, and there above on the head bar, you will find all the links. You can go from there also. It's easier that way. All right. So let me ask the team. Do we have more questions from Dr. Habchi? And to our attendees in the meeting room as well. Yeah.
Prof. Jeta Aisha, what are the surgical management you recommended? I say that the surgical resection is remain the first line of the treatment, but it differs according to the location and also some factors as injury or when we have a deeper location of meningioma, we cannot do a surgical removal of the tumor cell. We use a stereotactic surgery, okay? And we do the biopsy, and in some cases, we can use, for the elderly person, you use the chemotherapy, radiotherapy, and this is the second line of the treatment. The surgical removal, so the surgical resection is the first line of the treatment. And as I say, it depends on the location and the state of the patient.
Yes, please go ahead, Dr. Asharji. If there is another question. Hello, Dr. Habchi. You are mute right now. Please unmute yourself, Dr. Habchi. Yeah.
For Sempurna, yes, for Sempurna, my answer is you have a problem or changes of behavior when the meningioma is located in frontal lobe. Okay, this is the answer.
There is another question from Dr. Acharji.
Sempurna, thank you. What will the palliative occur when we can plan for meningioma patient? So the palliative occur, the first line treatment is surgery resection. The palliative treatment are chemotherapy, hormone therapy, medical treatment, and stereotactic radiosurgery. This is the palliative treatment. For the case who in the cases when we cannot do the surgical resection, so we use this palliative care.
Thank you for the answer. Any more questions? There is.
How we can what? Measure what?
It's ICP. Can you please write it in the full form? Dear Kadir.
Index of what?
How can we measure?
Intracranial pressure. We have some method. This is another field. This is we have instrument specific instrument to measure this intracranial pressure. Okay, I will present to you in another session the technique to measure this intracranial pressure. Okay. I will show you the techniques. I explained, but I am sure that you don't understand without seeing the image. We have a specific technique to measure this intracranial pressure, okay? I promise to you that in the future, I'll show to you how we measure this intracranial pressure.
Perfect. That's so kind of you to always take the queries and provide the answers to them. Okay, so I would like to announce a thing that we were having questions on LinkedIn, and our team tried our best to extract the questions as much as they can from LinkedIn. In case we missed your question, please write down your questions once again so I can read the question for you here.
Yes, in the case of severe condition, can borehole craniotomy procedure should be done, yes? In the Simpson, if you see in the first grade of Simpson grading, we have in the case of symptom grade 1, we do this craniotomy procedure. So is sinuses infection symptom of meningitis? No. Sinus infection symptom? Yes. Here, meningitis and not meningioma. It's not our item. So, Okonko, can a minor head injury lead? No. There is not a correlation between the injury and the emergence or occurrence of meningioma. No. Because I read the latest article published this year, I don't find that there is a correlation between injury and occurrence of meningioma. They show that there is a correlation between harmonious and the emergence of the skin of a tumor. And they precise the different subtypes according to the location. If there is a connection or a link between an injury of and meningioma, they present them in this latest article. For my information, I follow the foundation, Sciences Foundation. And for the classification, I use the World Health Organization classification. Nora Timas, are there alerting signs for meningioma? If so, what are they? So, for, if you remember, I showed that the skin of a tumor grows slowly. In some cases, it is asymptomatic. I do a CT scan and I show this mass. For these cases, we will have a clinical and MRI observation. However, when we have a sudden onset of a vision or changes of a vision or sudden change of memory, when we have a headaches or decrease of a hearing, here we must seek to emergency. Okay? What is the risk factor for meningioma? I show this. When a woman have more than 3 children before the age of 40 years and take progestin, this is the first risk factor. This is the first one. Second risk factor is radiation. Third risk factor, we have some hereditary disease as neurofibromatosis 2. This is kind of disease is correlated to the emergence of meningioma. Also, in the last article, I found that there is a correlation between the obesity and the emergence of this meningioma. I pose a question. Most of the women, African women, have this problem of obesity. What is the explanation? Here, the explanation is about the mechanism is correlated to the hormonal receptor. So this hormonal receptor is correlated to the emergence and occurrence of obesity. This is why the researchers try to find what is the connection between the occurrence of meningioma and obesity. The first explanation is the hormonal theory. The taking progestin leads to the emergence of obesity. It is a consequences of taking progestin. So this progestin leads to emergence of the obesity, and in another side, lead to the occurrence and the growth of meningioma. This is the risk factors of occurrence of meningioma.
I see Dr. Habchi is taking all the questions very energetically and very interestingly.
Thank you very much.
So let me ask team, do we have more questions or did we miss any question? Yeah. All right.
What are the type of meningioma? I showed to you the histopathological and etiological classification of WHO of 2016. I show you that we have 3 kinds of meningioma. We have the grade 1, the benign tumor, grade 2, atypical tumor, and grade 3, anaplastic tumor. This is the 3 grades of meningioma according to 2016 WHO classification. And this classification is based on histopathological characteristic, and also in the last WHO classification of 2021, there is introduction of biomarker, the alteration of some markers. And I show you in the latest article of this year that there is a correlation between the subtypes of meningioma and the location. And also there is a correlation between the alteration of a marker and location of meningioma. So the answer is the classification is according to the location, and second classification is WHO classification of 2016. In WHO classification, we have 3 grades and 15 subtypes. Okay? No. Does chronic meningitis lead to eventually meningioma? No. If the sinus infection is a symptom of meningitis, yes. Symptomatically, the sinusitis can confuse with meningioma. Yes, in these cases, you must take a care provider. And here in these cases, there is a radiological exploration. So the imagine show if you have a problem of meningioma or sinuses. Okay? If you want to know the difference between these 2 diseases, you must go to the doctor and have imaging. Okay?
I don't think there might be any more details while answering the questions which Dr. Habchi provides. So, yes, Mr. Wakil, I'm thankful to Dr. Habchi as well. Thank you to all of you for asking the questions, and thank you to Dr. Habchi for taking the questions. And
thank you very much for you.
Yeah, so we are having a question answer session at the end of the event also. That is after the talk from Dr. Mehdi Dermoul. So we will continue the questions that time. And before I announce our next talk, I would like to state a thing. Let me ask for the info details for the certificate. Yeah.
Today we have more attendees according to the last time, huh? If you compare the
Yes,
last time, yeah, this is today we have more attendee, more interesting question. It's a good, huh?
indeed. The management itself selected the attendees, and we could have more attendees as we are having many people asking for how they can register for the event in the LinkedIn session. So we will try our best to provide them with the links and the easy registration process from the next event, as we are still improvising our events. So any suggestions from any of you are welcome from all shares. Yes, Dr. Acharji, there will be certificates. Okay, about the certificate. I would like to ask to all of you to please provide your full name along with the title, as it is Mr., Miss, Mrs., Doctor, Professor, all right, and your email address. Please make sure the email address is correct. Yeah, please write down all these details in the chat box. That is for the certificate preparations. And I repeat, the certificates will be provided to only those attendees who are present in the meeting room right now. Thank you. So we are just taking 2 minutes for this. Afterwards, we will move to our next speaker.
Good evening, everybody. First of all, I would like to thank the organizing committee of this webinar, and especially the conference moderator and Dr. Nawel Habchi for the invitation to the webinar. I will share my, I will talk about the surgical management of sacral chordoma, the specific subject, and I will share my screen.
All right. Till then, let me take a few seconds to welcome Dr. Mehdi Dermoul, Professor Mehdi Dermoul. Welcome to today's event, Professor.
Thank you. Thank you very much. I will share my screen. Yes. I will talk about surgical management of sacral chordoma, and we talk about our experience with illustrative cases. It is a specific subject for neurosurgeon. Sacral chordoma are a rare malignant bone tumor. They account about 1 to 4% of all primary bone tumors, with an incidence rate of 0.08 per 100,000 inhabitants. Their origin, embryological origin, from the vestigial element of the notochord, and the diagnosis is usually made at the peak age of the 5th decade, with a predominance for the male gender. Most commonly, the tumor arises in the sacrum. In the sacrum, the cordom is represent more than 50% of all tumor of the sacrum. They present with the slow progression, progressively with symptom, progressively they present with symptom, and the diagnosis is usually made later. This is later diagnosis, and the symptoms are poorly specific, non-specific, and frequently we encounter deep pain and or radiculopathy. The diagnosis is made by the radiology. The CT scan showed a destructive bone lesion involving the vertebral body of the sacrum. The MRI showed soft tissue mass, hyperintense on T2, and heterogeneity contrast enhancing with local invasion to the adjacent disc spaces. And due to extensive disease progression at the time of presentation and the high rate of local recurrence, these lesions require multidisciplinary management. And the gold standard of the treatment is the resection, is en bloc resection, the total resection. Radiotherapy can stabilize the patient for 5 years, and the vesico-genitosphincteral neurologic sequelae and disorder are frequent. The quality of initial treatment determines the recurrence and the survival, the rate of recurrence and the survival. And actually, we have immunotherapy is an ongoing line of research.
Ask me what you want. You want to cook the food?
We will present our case series. Our case series, we conduct a retrospective study in our department of neurosurgery in Monastir department from 2019 to 2022, 4 years, and we find 5 cases, 5 males aged from 52 to 86 years old with a mean age of 70 years old. The clinical presentation are sacral pain in all patients, S1 radiculalgia in 1 patient, palpable sacral mass in 2 patients, in 2 cases, vesicosphincter disorder in almost all patients, and perineal hypoesthesia in 1 case, and we didn't find any motor deficit. Okay. On radiological investigation, the CT scan showed in almost all cases a huge osteolytic mass with invasion of soft tissue like this image, and MRI showed huge lesion, hyposignal on T1, hypersignal in T2 with marked contrast enhancement. Like this image, MRI with a huge sacral lesion markedly enhanced by contrast. And all patients underwent surgery by posterior approach, and we obtained total removal of the lesion in 2 cases, subtotal in 2 cases, and partial in 1 cases, and all patients underwent postoperative radiotherapy. After a mean follow-up of 28 months, we obtain recurrence in 3 cases, and 2 are reoperated, and 1 died at 13 months with lung metastasis. We will illustrate our presentation by an interesting case. This case is a 79-year-old man with history of controlled hypertension and benign prostatic hyperplasia, who was admitted to our neurosurgery department with a slow-growing, large, hard mass of the sacral region, which became easily palpable over the previous 2 months, and he also suffered chronic constipation. A pelvic magnetic resonance imaging was consistent for a sacrococcygeal mass extending to S2, the second vertebra of the sacrum, left piriform aperture dorsally and superiorly to the paraspinous muscle at S2. The lesion measured in the long diameter, 15 centimeters in its long diameter. And this is the MRI, sagittal huge mass, especially in the S3 and S4 and S5, below S2, and here after contrast enhancement, markedly enhanced by the contrast. The lesion is markedly enhanced by the contrast. Here in frontal view of the MRI. And the patient underwent extensive open surgery to achieve complete resection of the sacral mass. After routine preoperative evaluation, the patient was placed under general anesthesia. in the prone position. A midline incision was made starting from L5 level. The sacral tumor was subsequently resected and excised from the pseudocapsule membrane with careful removal of the residual tumor and the capsular tissue to reduce the likelihood of recurrence. The cavity was flushed with a large amount of normal saline. Bleeding was controlled, and the drainage tube was placed, and the incision was closed using suture. Transfusion was required based on an estimated intraoperative blood loss of 1,000 milliliters. This is a photography, perioperative photography showing the complete removal of the lesion and the intact posterior rectal wall with excellent hemostasis. And on postoperative, there were no any neurological deficit, nor bladder or bowel-related complication, and both S2 roots were preserved. And neurosurgery for postoperative CSF leakage was needed with good outcome. The histopathology analysis showed the tumor specimen revealed intracytoplasmic mucin-like substance with large nuclei, deep staining, and an irregular matrix that resembled. And the final diagnosis was sacral chordoma. This is the postoperative MRI showing the complete resection of the tumor. This is a frontal view of the MRI showing also the complete resection of the lesion. After contrast, we have no lesion. And in this case, the reported technique allowed high sacral resection through S2, S3 with only a posterior approach with the intention of achieving radical removal, which is successful. It is less invasive with minimal morbidity, and the major technical problem were the margin of the tumor and the excision in the sacrum itself and in the peripheral soft tissue, and the preservation of sacral nerve roots. And the patient was sent for radiotherapy. For the management of sacral chordoma, we review the recent literature. And we have many recent articles, such as this one, another recent article, the sacral chordoma margin, another posterior only approach for en bloc resection, clinical outcome in 36 consecutive patients. Many recent articles deal with this pathology, and we review the recent literature in this for the management of sacral chordoma, the surgical management of sacral chordoma. And after this review, and after we will resume the strategy, the management strategy of sacral chordoma. This entity is a challenging clinical entity due to often large tumor size and advanced disease encountered at the time of presentation. Treatment can require multiple discipline and incur risk of morbidity and decrease of the quality of life. Surgical resection, especially the total resection en bloc resection, remains the definitive method of preventing recurrence and minimizing overall mortality. And the prognostic factor depend on the tumor size, more than 8 centimeters, infiltration of the sacroiliac joint or adjacent structure, especially the musculature and gluteus maximus or piriformis invasion. The principle of the surgery, the operative approach to sacral chordoma is tailored to the lesion size and the relationship of the adjacent structure, especially the sacrum, the sacroiliac joint, and sacral nerve roots. The appropriate surgical approach is recommended according to tumor location. And for small and localized tumor below S3, the posterior approach is proposed. And for tumors located above S3, a combined or anterior transabdominal approach is suggested depending on the need for bone resection and the experience of the surgeon. Lumbopelvic reconstruction with instrumented fusion is recommended in cases involving the joint, the sacroiliac joint, if the majority of the sacroiliac joint, or when a total or high sacrectomy is performed. Postoperative complication related to pressure-dependent wound breakdown and infection are source of morbidity following sacrectomy. Then collaboration with plastic surgery for a layered wound closure with or without a flap is beneficial. The neurology, what are the neurological outcomes? The neurological outcomes depend on the involvement of the nerve roots. If we have involvement of both bilateral nerve root above S2, we will have from S2 to S5. We have the bowel and the bladder dysfunction in almost all cases. And if we have unilateral nerve root sparing is associated with improved neurological outcomes and recovery with of the function, bowel and function at approximately 6 to 8 months. Unilateral preservation of S3 carries 67 and 60% chance of intact bowel and bladder function. Radiotherapy, what is the role of radiotherapy in the sacral chordoma? The role of adjuvant radiotherapy still remains controversial. Chordoma are considered to be poorly responsive to traditional radiation therapy technique. Actually, the development of stereotactic radiosurgery technique, however, raises the possibility of increasing the application of this technique to the tumor with improved outcomes. High-dose single fraction stereotactic radiosurgery has been shown to control local disease in approximately 95% of patients at 24 months. And actually, also the proton beam therapy may also represent a promising therapeutic avenue, and 5-year local control was seen in patients are reported as 90% for primary and 57% for recurrent lesion. Radiotherapy may also delay the time to local recurrence, specifically in patients with partial resection. Reoperation after recurrence. When recurrence does occur, it commonly involves the soft tissue around the sacrum, including the muscle, piriformis and gluteus maximus muscle. There may be a role for reoperation, but this reoperation should be complete with complete resection. And the reoperation there are difficulties in the reoperation due to scarring and obscure the tumor margins. What are the message you should take to your home? Sacral chordoma is a complex clinical entity which often presents in a delayed fashion, leading to a large tumor size and involvement of critical neural element in the sacrococcygeal region. En bloc resection with a multidisciplinary team of colorectal and wound specialists is the gold standard for limiting recurrence and maximizing survival. The role of radiotherapy as an adjuvant or in recurrence still remains unclear, and for patients who cannot tolerate an operation, radiation may provide a less optimal option for to control the disease in a limited fashion. And thank you for your attention. Thank you. This is a specific pathology for the neurosurgeon, especially for neurosurgery. This is a rare pathology which affects the sacrum, the end of the spine, the sacrum, the end part of the spine, and it's a rare lesion. And the treatment is essentially surgical treatment and the radiotherapy is still controversial and can be done in the elderly patient and the patient who cannot tolerate surgery. Thank you.
Perfect.
Yeah.
That was, yeah, I'm sorry.
If you have any question of this pathology, is a rare pathology.
So I don't need to.
Difficult to treat.
Yeah. So that was the additional knowledge also. I don't think I need to say anything, but definitely I would like to thank Dr. Mehdi Dermoul for providing his precious time to us and joining the meeting today. Yeah, thank you for the talk.
Thank you very much.
Let's ask for the questions. If anybody having any questions to be asked from Dr. Mehdi Dermoul, please go ahead, ask your questions. To those in the meeting room right now, you can ask your questions or anything you are having to discuss with Dr. Dermoul. Please go ahead. Till then, I would like to announce that those who are having question in the LinkedIn Live, they can write down their questions also. There is a question in the chat box.
What's the question?
Should I read it out for you, doctor?
What is the question?
Yes, the question is, can radiotherapy cure a brain tumor?
Huh? Can?
Radiotherapy cure a brain tumor?
A brain tumor. We talk here about a sacral tumor, not a brain tumor. But for brain tumor, some radiosurgery can cure some tumor. Yes, can in the brain, especially in difficult location like cavernous sinus and in the foramen jugular. In the foramen jugular, yes. In some location, radiotherapy can be the first line treatment for some brain tumor. Yes, but in this talk, I deal with the sacral spine tumor, not brain tumor. The sacral chordoma. Chordoma, yes, maybe seen in the brain, especially in the clivus, in the bone. It is a bone tumor, and the chordoma can be seen in the brain and in the spine. Yes, and in the brain can be treated also by proton beam therapy. We can do the diagnosis by biopsy, and we can also treat by proton therapy. Yes.
Thank you for
it is
the
a malignant
answer.
tumor.
There is one more thing I would like to state here, that those who are in the meeting room right now, it's not necessary that you will write the question in the chat room. That is just in the case you are at some noisy place, or you can't at that time come up on the screen. Otherwise, it's open to please unmute yourself, come up on your screens and ask your questions and discuss about whatever you want to discuss with the speakers. It's totally your choice. Yeah. So thank you for the question, Mr. Bakir. So I'm asking for any more questions we are having. There is one more question. The question is, what are the different types of chordoma?
different types.
Yes.
Chordoma, there is only one type of chordoma, but different location in the brain, in the spine, and
dear attendees, whosoever is unmute, please mute yourself. It's Maisa.
Yes. لا خلاص أنا مش عارفة.
Would you like to ask something from Dr. Dermoul?
No, thanks.
Yeah, I'm sorry, you were unmute. And Dr. Dermoul got interrupted in a way.
what is the
thank you for
expected
cooperating.
prognosis? The expected prognosis for sacral chordoma. The overall survival of sacral chordoma is about 60% at 5 years. It is a malignant tumor, and we should treat this malignant tumor with because the survival is the overall survival is about 60% at 5 years, and we can see also morbidity, frequent morbidity, and bladder dysfunction and bowel dysfunction, and we should treat this lesion, especially in the young patient. Should remove surgically this lesion. Yes.
There is one more question from Mr. Wakil. It's is chordoma curable or not?
Hello, I have a question.
Yes.
So this is Dia from Sweden. So in practice, we see many older patients with back pain and constipation. I would just like to ask, what is the incidence of this so that we can start thinking about it? Or what are other risk factors that makes us start thinking in this line more if they have like a bit of back pain, some urinary problems, even constipation, that, okay, we might be start thinking in that way too.
Especially pain in the sacral region and mass, palpable mass in the sacral region. We should think about this sacral chordoma. Pain in the sacral region, pain and mass, palpable mass. We should think to this lesion, and we should do MRI and CT scan of the sacrum, especially at the fifth decade. It's at the fifth decade. Okay, not for the young. For the young, it's a tumor. Generally, the diagnosis is made at the fifth and the sixth decade of. Okay.
Thank you, Mr. Dayar, for your question. All right. There was one more question from Mr. Wakil. And yeah, I would like to praise Mr. Dayar to come up on the screen and ask his question directly. This is how I want the questions to come up, as I and the speaker with me won't be feeling like we are only communicating with each other. We really want our attendees and other speakers to come up between the conversations and discuss the things. Please be comfortable. So the question from Mr. Wakil is derma curable or not?
Yes, yes. If we have the lesion, small lesion, and if we do surgery complete resection, we have a good rate of survival. Yes, it can achieve 90 to more than 90% at 5 and 10 years. The survival. Yes, if we do the diagnostic early. With an early diagnostic and small lesion without invasion of the surrounding structure, it can be curable. Yes.
Perfect. So any more questions? And I would like to just take a moment to. One second. There's one more question before I even ask the next. There is a question. Should I read the question? That's okay, Dr. Dermoul. Please take your time. Be comfortable.
Yes. What is the difference subtotal and partial resection, and when we do this? Subtotal resection, we will do subtotal or partial resection when the lesion, when there is invasion of the rectum and invasion of all surrounding structure, and especially in the elderly patient. We do partial resection and we complete with radiotherapy to stabilize the lesion. And for a young and small lesion, we do the total resection. We should do the total without invasion, because if the surrounding structure, especially the nerve roots and all the bone, the joint, sacral joint, and the abdominal, the rectum are invaded, it is difficult to remove all the lesion, and we'll do subtotal or partial resection. Okay.
Nice. Thank you for answering the question. So any more questions? Dear team, if you find more questions in the LinkedIn, please come up with the questions. Okay, there are. But Mr. Wakil, you are asking the questions directly to me. That's why Dr. Dermoul is unable to see the questions in the chat room. So please make sure you are asking the questions to everyone. This is the technical error which happens generally with us. If you want, I can copy the question and paste it here. And even if, as you are available in the meeting room, why don't you just come up on the screen and ask the question directly, as you are asking really interesting questions.
Mm-hmm.
Before that, we are having a question. Yep. Oh, please don't be sorry. That's totally fine. I do understand the errors we face. We actually face it every day. So the question is from Ismail. What's the main differences, subtotal and partial resection in terms of surgery? Are both the same or different terms?
Mm-hmm. Subtotal resection, when we keep less than 10% of the lesion, and partial when we keep more than 50% of the lesion, partial. And surgery are both the same. No, not both, not the same. Partial is different from subtotal. Subtotal near total. Near total. We keep only less than 10% of the lesion, and partial less than 50%. Okay. The epidemiology, it is rare 1 to 4 of all the tumor of the bone and especially the chordoma in the sacrum. It represents the frequent in the sacrum. For all the tumor of the sacrum, it represents more than 50% of the tumor of the sacrum. The chordoma is the chordoma can be found in the cranium, in the clivus, in the cervical spine, in the dorsal spine, and in the sacrum. It is frequent. Okay. The etiology, embryological origin from vestigial of the notochord. I tell this in the first of my slide. The first slide I put this the etiology of the sacral chordoma, the embryologic origin of the sacral chordoma. The diagnosis is made by the histological analysis. The pathology, the histologic analysis confirm the diagnosis of chordoma with the imaging, the MRI and the CT scan. The diagnosis probably chordoma is suspected and confirmed by the diagnosis is confirmed by the histology analysis, histological analysis. We remove the tumor when completely, if it is not invading all the surrounding structure, we can remove it completely. And if with the pseudocapsule of the tumor, and this is the best way to resect totally this lesion. And for the anatomy, if we have invasion of the joint, sacral joint, we should reconstruct. We should do fixation of the this joint of the end of the spine with the iliac bone. Okay. If we resect all the sacrum, we should fix the end of the spine to the iliac bone, the bilateral of the both iliac bone. We should do a fusion and okay, should fix the end of the spine. The lower spine, yes. Thank you.
Any more questions? And we are sorry in case we missed any questions earlier from our attendees in the meeting room right now. In case we missed the questions, please repeat your questions here. Kindly repeat your questions here. In case we missed them in the flow. Also, to people who are watching us live on LinkedIn, you can ask your questions in the comment section. We are trying our best to provide you the answers by pasting your questions in the meeting room right now. So, Mr. Wakil, did you get the answers of all of your questions? That's great. And please call me Ghazal. There's no need to call me ma'am. I feel more connected with people when you call me Ghazal. This way it's more comfortable to me. Thank you. So, dear team, please confirm if we are still having questions in the LinkedIn Live for Dr. Dermoul. Also, there's one more thing I would like to announce that we are having different conference groups, the discussion groups for each conference, as we are having a series of conferences for different dates. So let me share the direct link for the discussion group for Neurosurgery 2023. That is our today's event. In case you feel your question was missed and you couldn't get the answer, and you are having more questions, please write down your questions in this link I'm providing here, and I'll make sure to provide the link in the LinkedIn section also, LinkedIn comment section also, so that you can write down your questions to us, and we will try our best to provide you with the answers for all of your questions. And thank you so much for asking the questions. This way, this is more clear to many others also. All right, it's neurosurgery, the discussion group. Thank you, Mr. Wakil. Okay, there is one more information. Thanks to you, I got that I should share. We are having a series of questions. So in case you want to join multiple events or all of our events, please make sure you subscribe to our website so you will be updated, and also the social media platforms. Please get connected with us on our social media platforms. We regularly announce about our upcoming events, upcoming speakers, the upcoming talk titles, and much more things. This way you will get all the information. Dear team, please help me sharing the link for discussion portal, discussion group in the LinkedIn session, LinkedIn Live as well. You're welcome. So I'm welcoming all any other questions you're having. Now it's the questionnaire session. Any question from Dr. Nawel Habchi and Dr. Mehdi Dermoul, from both of our speakers or from us, please come up with your questions. Feel free to ask your questions. Be comfortable. It's the questionnaire session right now, as we are done with our both of the talk of the day. Afterwards, Dr. Habchi has something to announce. And we are from Al Shiazar very much thankful to both of our speakers for taking the time out to explain the things related. Yeah, exactly, the surprise.
Okay, no problem. So for the surprise, I asked you the publication of our first issue. We have launched it at the end of April, and after a hard work with the editorial board, so we have this publication of the first issue. So you posed a question about our review. So I will give you some information about our editorial board and the objective of the publication of our article review. So here I shall read you this. You can see it. Okay, so the online conference International Association Society will be launched a new quarterly article review for the researcher, and it is it is a synthesis of the information of our speaker conference. So each issue will contain 10 or 9 or 10 articles selected by our editorial team with a highest quality of content. We invite all conference speakers with original research to submit their work in the future issue. So the submitting an article is a very straightforward. Once you have presented your research in our conference, you may submit your article for this review. Our editorial team will carefully evaluate your work to determine if it is published or not, and we have some information to present to you in order to respect them. You pose the question, what are the benefits of the publication? If your article is selected for publication, it will be included in the quarterly issue for the article review. It is an excellent opportunity for you to showcase of your research and hard working, okay? It is a form of recognition, okay? If you want to present your hard work and dedication, you can submit your work in our review. Now we pass to editorial abort. I am editor-in-chief, and I have co-editor-in-chief, Professor Mehdi Dermoul, who is the head of the Department of Neurosurgery of Monastir Hospital, and he is the president of Tunisian Neurosurgery Society. And also, my dear Professor Samperna, who has really worked hardly this period, she helped me in the work in the correction of this the article of this first issue. For the co-editors, we have Moroccan member, the Kali Zahra, who is a psychologist. We have a professor associate, the Indian professor associate, Jyotirham, who is associate professor in obstetric and nursing, obstetric and gynecological nursing in India. We have the Greek author, Calliope Magari. And also we have the 3 Algerian neurosurgeons, Professor Bouallag Magdouda and Dr. Agar Sabrina, who work at the hospital of Mustafa Basha, at the Department of Neurosurgery of Mustafa Basha Hospital at Algiers, the capital of Algeria. And in the West, we have our leader, Professor Daoud Souad, who is a professor. She is a neurosurgeon at Oran Hospital. I thank you for her because she helped me in the collection of the article of this first issue. The instruction to submit an article for consideration is available in this link. You can take a picture. And when you submit your article, you must have this information like the name, mail, affiliation, the title of your presentation, and you can present your work in a form of Microsoft Word or a PDF format. And we hope that you use the biography of you, because we want in the future to present some biography on some authors. By submitting your article, you confirm that your work is original and not been previously published. All submission will be reviewed by our team, and we don't guarantee the publication of the work. This work must respect this information. This is the first issue. The type of this first issue published at the end of this month. You can get it at this link. The first issue is available through this link, and the categories of review is neurosciences, neurosurgery, oncology, psychology, and human behavior. This is the different field or category of review for this first issue. Look here. We have 9 articles. This is the title, the 5 first title of our first issue. Here, Professor Boualek has presented one kind of brain injury, a pediatric chronic subdural hematoma. She presents a case report and she compares the result with a literature review. Also, we have the biology of Parkinson's disease. And we have the epilepsy, the field, the disease of epilepsy. This is a very important, very important article published by a Brazilian neurosurgeon. He is a very famous neurosurgeon. And also, Asia Alal, in the last conference of career development, she presented this work, the new method for controlling cerebral aneurysm. And this is very important for the physician and also for the neurosurgeon. Here, the physician and the neurosurgeon work together in order to develop this kind of the article. Asia Alal is a physician, it is not a doctor. So she used this Raynaud number in order to now the correlation between the direction of aneurysm and the size of aneurysm. It is very, very important. So she presented her conference in the career development, and then she transformed her work in a form of article. Also, Professor Bek Khalas, who is head of Department of Neurosurgery of the Hospital of Béjaïa, have this therapeutical modality of glioblastoma, and she proposed a management protocol. She had published one thesis about glioblastoma, and she summarized all her work, and she presented for you this article. It is very important for the proposed management protocol for the glioblastoma. Glioblastoma is a malignant a tumor, and all neurosurgeons search the proposed management protocol. So you can use this article as a proposed management protocol for the management of glioblastoma. This is all the idea about our first issue, and I invite you to submit your original work in the future issue. So the future issue will publish it normally in October, after FEMA. So I invite Professor Mehdi Dermoul to submit or to submit his work in our in our issue. It is very interesting work. It is a rare pathology. So I invite Professor Dermoul to present this case report in our issue. Okay. I invite Professor Suad Dawood to give her opinion.
Good day for everyone. It's
Thank you
an
very
honor
much for your help.
It's an honor for me to be with you in this meeting. I start by thank my friend Nawel. Thank you, Nawel. I am very happy to help my friend Nawel and to work together so to improvement this journal and to help the young neurosurgeon, the young researcher to publish their work and to improvement this journal. I hope to work together hardly. So thank you, Nawel.
Thank you very much for your help. Collection of the article.
Thank you, Nawel.
This is why I proposed.
You are on mute, Dr. Habchi. I'm sorry. Please unmute yourself.
Okay, now, okay. So I invite Dr. Agar to give her opinion. Dr. Agar, can you join the group?
Yes, hi everybody, do you hear me?
Yes,
Yes.
perfectly.
So I'm really glad to be here with you. So hello everybody, I'm really happy to join the editorial team. I would thank you for all for giving me the chance to be part of this project, especially Dr. Habchi. Thank you for offering me this opportunity. I'm sure that we'll do in the future a great job with the next issue and others.
Inshallah.
Inshallah.
Thank you very much, Sabrina.
Thank you.
I want to hear the son of Dr. Saparnam.
Yes, Habchi madam, I'm here with you.
Thank you very much for your help. Huh? You have
Yes,
really worked hardly. Yeah?
Great pleasure. So in future, I may collect some articles for you. Even
Yes.
I'm also doing many research work. So I'll make it for you, ma'am. Surely, I'll send articles.
Thank you very much. Thank you very much. And I invite Professor Dermoul. Where is it? Professor Dermoul?
Yes.
Professor Dermoul.
Yes.
Yeah.
You are
Yes.
here?
Yes, I am here. I am with you. Yes. It's very interesting. Yes, we will support you, and we will in the next issue we will maybe publish some article. Yes.
Inshallah.
Inshallah.
Your case is very, very important.
Okay.
Okay.
I will send it to you for publication. Yes.
Okay. Thank you very much.
Okay. Thank you.
And
for the Greek author.
yeah, let me help you with the pronunciation. Let me help you with the pronunciation,
Exactly.
Dr. Habchi.
I have
Yeah.
the.
It's Dr. Jyoti Lakshmi.
She is here.
Yes.
Yeah, hi. Hi to
Sorry for the
everyone.
pronunciation.
First of all, I must thank you for giving me the opportunity, ma'am. Ma'am, could you able to hear?
Yes, perfectly.
Hello. Yes, ma'am. Yes, ma'am. Sure, ma'am. Sure, I'll join with you with some articles, ma'am. Sure.
Thank you very much for your
Sure.
help.
Okay. Okay.
And for the Greek author, Calliope Magari.
Dr. Calliope was busy with the case today. Hopefully, she will be joining us in future.
Okay, it is the same case of Professor Boualag Magdouma.
Yeah.
Okay.
We will definitely call them and ask them to join us for our future events. Any of the event they can provide their time for.
And for the Kali?
Yeah. For the questions, dear team. Dr. Habchi, I have also provided the link for the discussion portal in case they are having questions and we missed the questions from the LinkedIn Live also. They will be posting the questions on our discussion portal. There you can directly take the questions. Yeah.
Okay.
Yeah. So this is because we might miss some of the questions and we must be fair with everyone. So this was the idea from our team. And thank you so much for taking the time out for our today's event, plus announcing the surprise. Thank you very much to Dr. Habchi, Nawel, Dr. Professor Mehdi, Dermoul, Dr. Sampurnam Webster, Dr. Dawad, and Dr. Jyoti Lakshmi, Dr. Agar. Thank you so much for joining us today for this announcement. It is a big encouragement to all Shias. This is very new to us to come up in the article review work, but thanks to you all and your support here and and your hard work and efforts you are putting in with us to make it a success. And by God's grace, yes, we are looking forward to very good results. Yeah.
Okay.
So, dear team, do we have more questions present, or I suggest that you provide the discussion portal link directly?
Directly, yes.
Yes, these questions will be direct. Thanks to you, Dr. Jyoti Lakshmi. And yes, I would like to know the pronunciation of each and every name. So in case I'm not pronouncing your name right, please make sure to correct me right there. This way, we'll be more comfortable with each other, I think. Yeah.
Yes, I'm sorry for Indian member. I didn't pronounce good her
Yeah,
name.
it's Dr. Jyoti Lakshmi. Try it. It's easy.
Okay, I repeat it.
Yeah, Dr. Jyoti Lakshmi.
Okay.
She has a very beautiful name. The meaning of her name is the goddess of the wealth.
Thank you very much for your participation, for the attendees. They asked a very interesting question. I'm very happy because in this conference, I noticed that there is very, very interesting question in comparison to the latest conference.
Yes. This time, the management chose the participants specifically for our speakers. So, yeah, this will go like
for Ismail, Do this platform have its own journal? If yes, is it a PubMed indexed for the indexed? Here, this is the first issue, and for the indexed journal, it will be indexed after in Scopus and PubMed when we have fourth regularly issue. This is the first issue.
Any more questions from you, from attendees in the meeting room or in the LinkedIn? Do we have such questions from the LinkedIn also? Dear team, please help us in reaching out Dr. Habchi to those questions so that we can provide the answers to the asked questions.
Also, I invite not only the speakers, the attendees can participate, can submit their work, original work. As I promised to the author before, I said a message that we will publish a new book in neurosciences. So we will define the pathologies, then the diagnosis, the methods of exploration. Then we publish at the end of each pathology the article. For instance, in the case of epilepsy, so we want to present the pathology, and at the end of the pathology, we publish the article of the Brazilian neurosurgeon. This is for the case of epilepsy. In the case of Parkinson's disease, we will carry out of this pathology. Then at the end, we will publish the parts of the Egyptian author who published the biology of Parkinsonism. So, for the instance, we have the parts of epilepsy, the parts of Parkinson's disease.
I hope it answers some of the questions. As Dr. Habchi is, it's her nature. I got to know that she wants to be specific and she wants to give as much details of something at the same time. So Dr. Habchi generally define the things in the most simplest ways to understand. And this is this is so much impressive thing I got to know about Dr. Habchi.
Thank you very much.
So anything else you would like to know or you would like to discuss? You can come up with your questions. And I have already provided the link for the discussion portal, and I hope that we have got the details I asked for. That was the title, the full name, and the email address for the certificate preparations from all of our present attendees. Please make sure you did that. All right, we are done with our talks of the day and the surprise also. We will definitely try to come up with more surprises in the future with the hardworking team we are having for the editorial reviews. Okay, so the team is trying to answer the questions on the LinkedIn platform also. Still, if any questions left there, please make sure to use the discussion portal or discussion group. And anywhere on LinkedIn or on any of our social media platforms, you will find the links for all of the events. Yes. As we noticed, there were so many people who were joining our today's event, they were from the psychology department. So it's good to announce, I think, about our upcoming event. Before that, we are having one more event. So let me announce both of them together. So after today, our next event will be on August 5th, and that will be on neuroplasticity and mental health. All right, August 5th, and it is for neuroplasticity and mental health. Afterwards, on August 19th, we'll be having our another event, which will be specifically for psychology and human behavior. So those who joined us from this department can join us for that event too. In case you want to present your talk or your research, please make sure to share your research abstract. All the links are provided on our website. And in case you want to be present in the meeting room from the next time, please make sure to register in advance, right? It'll be easier for you to be in the meeting room and ask your questions and directly interact with the speakers. So that is it. We are done for our today's schedule, and special thanks to Dr. Habchi Nawel for sharing the event and bringing out the surprise and introduce our editorial team also. All right. Thank you so much. This was it. Thank you so much to Dr. Mehdi Dermoul also.
Thank you. Thank you very much.
Thank you for taking your time out. To all of our dear honorable editorial team members, to our speakers, to our dear attendees, thank you so much for taking your time out and coming up in our today's event, joining us here or in the live meeting as well. Thank you. And we'll be definitely meeting you again in our further upcoming series of the events. Thank you. And it was Ghazal Johar for all of you. We are done with our today's event for neurosurgery. Let's meet in our next event on neuroplasticity. Thank you so much. And here we would like to end this today's meeting. Please make sure you have shared your details in the chat room. Yeah. Thank you. Thanks a lot. Thank you, Dr. Habchi. Please take care of yourself.
Thank you very much.
Yeah.
See you.
See you again, everyone. Bye-bye.
Bye-bye.